working. So I don't intend to take the 15 minutes. So उसमें से कुछ already जा भी चुके. अच्छा, so basically what we have to realize is that go back to how the pathophysiology of diabetic macular edema starts. Hello, am I audible? Hello, sir, are you?
हेलो हेलो
आप बोलते हो तो आती है, मैं बोलती हूँ तो नहीं आती. माइक डजंट लाइक मी. अच्छा, तो पैथोफिजियोलॉजी ऑफ डायबिटिक मैकुलर एडीमा इज़ वेरी इंपॉर्टेंट टू अंडरस्टैंड, ताकि आपको समझ आए कि ये सारे मॉलिक्यूल्स what we're using, how they work and at what level they're working. So just to go over the basics, and I'm sure
most of us already know this, but so there are two main molecules involved.
हेलो
Hello? Okay. Acha, so there are two main molecules in play here. One is the vascular endothelial growth factor, and the other is the placental growth factor. So it's not just VEGF, which is the sole sort of molecule responsible, because we all keep talking about anti-VEGF, but there are other molecules in play. And just to give it like a practical extension, all of us have got patients in our clinic that are not responding to anti-VEGFs. So there's your clue, that there's a lot of other cytokines and inflammatory mediators that are in play. But of the two more important ones are the VEGF and the placental growth factor. And evidence have shown that they are increased in patients with diabetic macular edema. There's upregulation of both the molecule level and also the molecular receptor. So what happens exactly is that when these molecules increase in amount within the vitreous and in the eye, the receptors are also upregulated, and when the receptors ko jo jaake molecule lagta hai, so it leads to a lot of activation of inflammation. So where does it start exactly is, we all remember from our physiology in 4th year that in microangiopathy involved with diabetes, there's rouleau formation and the RBCs become very sticky. अब वहाँ से start होती है सारी story. Once they become sticky, they cause occlusion, and occlusion leads to hypoxia. So when you're talking about microangiopathy, you're talking about the occlusion leading to the hypoxia, and that leading to increased hypoxia is sort of like a stimulant to increasing VEGF levels and platelet-derived growth factors levels. And these then activate their respective respective receptors and lead to a lot of inflammation. So there's activation of microglia and monocytes. There's endothelial cell apoptosis, so self-death of the endothelial cells which are lining the blood vessels. Now, when that lining is degenerating or leading to a process of apoptosis, there's increased leakiness from the vessels. Now, where does that sound familiar? This is what is showing up on your FFA and your OCT, with increased macular edema, increased retinal volume, and leakage on FFA. So this is the pathophysiology that is involved. Not only to endothelial cells apoptosis is occurring, but also opening of the tight junctions. So this increases the vascular permeability and leads to the main sort of edema of the diabetic tissue. And then neovascular formation, neovascularization. So this leads to the proliferative component of the diabetic retinopathy. All of them mediated by VEGF receptor activation, by the VEGF molecule, as well as the placental growth factor, which was influenced by hypoxia. And then, of course, that leads to the vascular leakage and edema. I feel like a medical college teacher right now. But anyway, but these are important factors to kind of revisit from time to time. So VEGF-A and placental growth factor, they act together through the VEGF receptors. अब इसमें जो VEGF and they play a critical role in the development of edema, retinal vascular pathology, inflammation, and neovascularization. So has anyone heard of the Quetta mice? So when they were developing Afibercept, they worked on the Quetta mice model. So mice को उन्होंने, because obviously we couldn't just start testing on humans, mice को उन्होंने genetically ऐसे reprogram किया था that the poor mice became diabetic. And once they were diabetic, that is when they took out samples from the vitreous and they realized all this evidence के जो हमारे पास आज available है कि उसमें VEGF levels up होते हैं और regulate receptors जो हैं up regulate होते हैं. So those Quetta mice, they led to what we know now, that Afibercept is the only globally available, now I'm choosing my words very carefully, anti-angiogenic drug that targets all VEGF1 ligands, including the distant pathways of VEGF-A and placental growth factor. Why is it globally? Is because Convacept, which we're going to be having a session on later in the day, that also inhibits placental growth factor as well. But it is being marketed in, local, in China and in limited few countries. So Afibercept incorporates domains from 2 VEGF receptors for tight binding, and not only is this tight, it is also the affinity of this molecule to the VEGF molecule is actually more than its native receptor. So जब competitive binding होती है तो the Afibercept has got a higher affinity for the VEGF molecule than its own receptor within the eye. And therefore that leads to that prolongedness of the duration of action of the Afibercept molecule. So I thank you all for your patient listening. And Hanan,
Thank you so much, ma'am. Now we'll be moving from the basics of Afibercept to the RCT trials of Afibercept, specifically speaking the grand trial protocol T for DME, which is in very basic terms called the CAT trial for DME. So it's a hallmark trial to be presented by Dr. Mustafa Kamal, sir.
Am I audible? Dr. Mustafa Kamal, I am basically, as one of my teachers, Dr. Said Iqbal, was saying that you are more into the cornea and LASIK and refractive things, but I do manage medical retina because at a teaching hospital, I work at Isra Foundation, Al Ibrahim Eye Hospital as a head of cornea department, but I am working at different 5 places at Karachi town, so I do practice medical retina as well. So this is very important when we see a lot of walk-in patients and people are aware of different variety of drugs, and actually they know, and everybody have Google in their hands. They can search and they can talk, and patients are so much aware of there. You must be having the patients who even know that what stage of diabetic retinopathy does they have in their eye. So people are so much aware. So this I would be discussing on the protocol T. This is the clinical trial done by conducted by DRCR, not by the buyer. So there aren't any financial interest. So this trial was conducted by DRCR in 89 cities of the USA, head-to-head trial, in which they recruited, the lowest age was 20 and the above was the age much as the patient was, of type 1 or type 2 patients who were having diabetic macular edema, and they were not improving on the previous injections. So what did they just pick one eye from the one patient, and they, from the randomized, it was clinically randomized trial. So what they did, so there was 660 patients conducted in this protocol T. So it was an international randomized multi-center study in patients with type 1 or type 2 diabetes, diabetic macular edema with central involvement, and the best corrected visual acuity was as good as 78 letters of the visual acuity on ETDRS chart, and the lowest was 24. So the range was from 0 to 100 actually, but the letters which patients visual acuity was like this. So Snellen's equivalent was 20/30 as good as 23/20 as bad. So one eye from each patient was randomized, and it was head-to-head trial, Afibercept was given dosage of 2 mg, ranibizumab 0.3 because 0.3 dosage is given to the patients in USA, although we have 0.5 mg. And this was all, recruited and decided by the DRCR. Bayer does not have nothing to do with this, the low dosage. And the bevacizumab of 1.25 mg. So one injection was given every 4 weeks to the patient, and they then follow the results by 1 year. So this is the result of 1 year protocol T. So what did they actually find? They see that vision gains with Afibercept were superior to those with ranibizumab and bevacizumab at the year 1 primary endpoint. So what did they do? They injected 9 median injections in 1 year. How did they go for? They injected 1 injection every 4 weekly Afibercept for 6 months, and then remaining 3 injections after every 2 months, and then they checked the visual acuity and outcomes of the patient. So at week 52 we have these results that you can see here, that this is the main gain of the letters. 13.3 letters were gained by 208 patients which were recruited in the group who got Afibercept. And this red curve is for the ranibizumab patients, and the green one is for the bevacizumab patients. So you can see here at the 1 year gap, and you can see that this is the sustained separation of gain in the best corrected visual acuity. You can see from the very first injection, the increase in the visual acuity is so much brisk and straightforward in those patients who actually underwent the Afibercept and who had Afibercept. As compared to those, this you can see, this is the proper curve maintained by the patients having ranibizumab and the bevacizumab. But this was a quite steep curve, straight curve for those who had the Afibercept injection. So 13.3 plus minus letters were gained by those patients who went for the Afibercept, 11.2 for the ranibizumab, and 9.7 letters were gained by those who had the bevacizumab injection. Now this is the protocol T tells us about that vision gains with Afibercept were maintained to year 2. So the second thing is that we noticed when we follow the patient and we saw that how many injections were given those who were under the group Afibercept. So only in first group, in first year we injected 9 injections in a year, and then in the second year we injected 5 Afibercept in a year, and then we compared the results. So what we found here, so there is the persistence of the increase in the visual acuity, and they persist, they did not go down. So the vision did not go down, and there was still the increase of 12.8 ETDRS letters at the end of 2 years, and with the ranibizumab there was increase of 12.3 letters, and with the bevacizumab there was increase of plus 10 letters at the end of 2 years in protocol T. So clinically meaningful vision gains. Now we have 2 scenarios, because this protocol T included young patients and the senile age group as well. So diabetic macular edema, and there were 2 groups as well. One group was having the good visual acuity, and the other group was having the less visual acuity or the bad vision. So those who had actually bad vision, they got advantage of this Afibercept a lot as compared to the one whose visual acuity was good. So if you can see here, now this is the baseline visual acuity of less than 69 letters. They have divided this result in 2 groups. One is better than 69 letters, and other is the less than 69 letters. So you can see here, so those whose vision was less than 69 letters, they gained 18.9, and they were 102 patients, because they divided the Afibercept group and all the groups into 2 groups, one with low vision and one with the good vision. So with low vision, 18.9 letters were actually gained by those who went for the Afibercept injection, and that maintained for 2 years. So at the end of 2 years, okay, and with those whose vision was actually better than 69 letters, so there wasn't any significant statistical significance between these 2 letters, between these 2 groups, like Afibercept and the ranibizumab. So for those, this injection is also good for those whose vision at the presentation is not good, or who have had the history of so many injections in past, like ranibizumab or any other injection, but their vision is not improving, right? Vision gains with Afibercept were superior to those I just mentioned with ranibizumab and bevacizumab in patients with baseline visual acuity less than 69 letters, and that is less than 20/40. You can see here that Afibercept versus bevacizumab there is statistical significance, but with Afibercept with ranibizumab there isn't any statistical significance. But this protocol T has focused on Afibercept and ranibizumab because these both drugs are FDA approved. But bevacizumab is not FDA approved. So many patients come to the clinic, they walk in and they ask, Dr. Saab, जो lens implant कर रहे हैं वो FDA approved है कि नहीं है? ठीक है. So we have such things. So we have to tell the patient. Now, for example, I work at a place, Patel Hospital. They have two groups. Either you go for Avastin or you go for Eylea. That's it. No Patizra. Because there wasn't any significant statistical significance between the Eylea and the Afibercept group, right? Eylea and the ranibizumab. So either you go for the Avastin if you do not have any comorbids, or you go for the Afibercept, because Afibercept is best in the world, globally available, as Dr. Hina said, and available everywhere. But here you can see at week 104 treatment protocol, there is the persistence increase and the maintenance of the visual acuity, what actually it was gained by those patients who underwent the Afibercept group. And with the ranibizumab, you can see there was 16.1 letter of the increase in the visual acuity on the ETDRS chart. I would like to comment one thing, because here, if there is increase of the 5 letters of visual acuity on ETDRS chart, it means there is increase in the visual acuity of 1 Snellen's line. So what do you think about the contrast sensitivity? The contrast sensitivity also increases with the visual acuity. So this also helps, but I don't know whether we do have the studies of contrast sensitivity comparison of these anti-VEGF or not. But if you think, for example, if the contrast sensitivity is good, vision is good, contrast sensitivity is good. If a patient is only diabetic and he has diabetic macular edema and he is well treated, but he is pseudophakic, he does not have glaucoma, and if you increase the visual acuity by injecting Afibercept 5 letters more than any other group, it means the 1 Snellen line's visual acuity has increased. It means the contrast sensitivity will definitely increase. And this is more helpful for those patients whose vision was actually less than 69 letters or less than 20/40. You driving at night, you parking car in dark light, watching steps in dark, dim light is very sensitive and very helpful for all those who does not have the good vision or who are of older age. So at year 1, Afibercept demonstrated advantages over either competitor in patients with baseline vision and less than 69 letters. So I just discussed, on average, greater improvement was seen with Afibercept than with the other agents. At worst initial levels of vision, Afibercept had a clinically meaningful advantage. At 2 years, in eyes with baseline visual acuity of 20/50 or worse, the advantage of Afibercept over ranibizumab noted at 1 year had decreased and was no longer statistically significant at 2 years, while Afibercept remained superior to bevacizumab. This is what I just commented, कि आप या Avastin या फिर Eylea. Now this is the AUC. AUC was an area under curve which states that the gain of visual acuity and the other group which actually you are compared with, the letters being compared, उसके नीचे जितनी area आपकी increase हुआ area of curve उसमें देखना है. So here you can see that the area of curve between the Eylea group, Afibercept and the ranibizumab is plus 3.4 letters, and it's very important. Even a single letter, single line is important for anyone to have good visual acuity. So I just discussed the area under curve, what it is. Now this is the protocol, the 5-year outcomes from the one. This is little bit fuzzy because after 2 years, every clinician did not follow the protocol. They injected injections on their own. So what they have told us at 5 years result that patients received a median of 4 anti-VEGF injections after year 2. This translates to approximately 1.3 injections per year. So what happened when they got injection 1.3 injections per year in 3rd, 4th or 5th year? What happened? There was dip from plus 14 letters of visual gain to plus 8, but still it's higher than the other groups. So the message is that if you keep on injecting on PRN basis, if you keep on following the patient and if you follow the patient and counsel the patient very well, this is what I see. I ask my patients to see me after 3 months. every 3 months I do the dilated fundus examination, and if I want to see if I feel like I should go for the OCT or there is dip in the visual acuity, then I definitely go for the OCT and compare, and I ask for the one more injection. So after 2 years it's on PRN basis, but if you go for, so what they have recommended that 4 injections a year after 2 years of the trial would sustain the visual acuity in the patients. So this is the last slide. Afibercept effectiveness and differentiation in diabetic macular edema, different trials. I would say that in VIVID and VISTA, rapid vision gains achieved with early intensive Afibercept treatment in the year 1 were maintained over 148 weeks, with fewer injections in years 2 and 3 compared with year 1. In endurance, patients from VISTA receiving Afibercept maintained visual acuity gains up to year 5. In Violet, Webber and Hirano, visual acuity gains were achieved with the majority of patients reaching treatment intervals of more than 12 weeks at year 2 with proactive T&E, treat and extend with Afibercept. In Protocol T, what we have learned is that Afibercept demonstrated advantages over ranibizumab and bevacizumab at year 1 only, and over 2 years in patients regardless of baseline vision. Thank you very much.
Thank you so much, Dr. Mustafa. Sir, I would like to add a few things to Dr. Mustafa's. Yeah. So both of these products, ranibizumab and Afibercept, are pretty expensive, and when the patient has to decide which one he has to go for, तो उसमें ranibizumab definitely is a bit cheaper देन Afibercept. उसने अगर कंसिस्टेंटली लगाना है और दोनों आंखों में DM ही है तो वो हमसे सवाल पूछता है कि विच वन इज़ बेटर. तो जो प्रोटोकॉल टी की वजह से 2 साल पे ranibizumab और Afibercept पर नियरली इक्वल, बट मैं उसको काउंसल करता हूँ पेशेंट को कि फर्स्ट ईयर में रैपिड राइज ऑफ विजुअल एक्विटी इसमें है, T10 एक्सटेंड की ऑप्शन इसमें है, साल में कम इंजेक्शंस इसमें लगेंगे, और ट्रायल में विजुअल गेन 2 साल में बराबर हुआ था, लेकिन सेकेंडरी आउटकम में DME का, CMT का डिक्रीज, सेंट्रल मैकुलर थिकनेस डिक्रीज ज़्यादा बेहतर Afibercept में थी. आपका जो सस्टेन्ड विजुअल एक्यूटी ज़्यादा बेहतर Afibercept में थी, लेस नंबर ऑफ इंजेक्शन ज़्यादा बेहतर Afibercept में थे. सिर्फ 2 साल के पॉइंट के ऊपर आपके बराबर हुआ था, नियरली बराबर हुआ था ranibizumab और Afibercept. ऑल अदर पैरामीटर्स और मैट्रिक्स जो थे वो Afibercept के पास ज़्यादा बेहतर थे. अब आई हैव रियल वर्ल्ड सिनेरियो क्वेश्चंस, बट आई वुड लव डॉक्टर आमिर अवान टू स्टार्ट विद द प्रेजेंटेशन फर्स्ट, देन आई वुड
which are randomized control, very calculated environment, very intensive treatment. But actually this doesn't happen when we are dealing with our patient. So it's really important. We want to have same sort of outcome what we are going to get in RCT. But unfortunately it doesn't happen. But there are a few good trials which have shown that how Afibercept is behaving in diabetic macular edema. So if we talk about Apollon, in which you can see early intensive treatment in the first year, you can achieve almost RCT-like visual gains. And if you look here, so that's the VIVID trial, which was initial VIVID and VISTA trials, you may remember, which were initially done. And that's a real-world Apollon trial. And even reasonable number of the patients here. And you can see that here, the patient's initial vision is better in comparison to here. So that's before starting the treatment. So that's why there is plus 6.5 letter improvement, but actually it's the vision as much as better it will be, definitely you can get less improvement. Poor the vision, yes, there are chances of getting more improvement. And we know that the driving vision is around 69 letter, more than 69 letters, then you can drive. And 40.8% were treatment naive patients who received 5 initial loading doses. So important thing is that initially you need to have intensive treatment for your patients, and later you can move on to 2 monthly or 8 weekly injections. So if you look here regarding VIVID and Apollon, you can see the comparable number of the injections. Even the visual gains greater than 2 lines, it's comparable, and even patient gaining greater than equal to 3 lines improvement, that is comparable. So it's almost similar outcome you can get with Apollon. So other important thing is that mean best corrected visual acuity that is gained in 12 months. So if we look at between with loading doses and without loading doses, we can see the difference here. So 5 loading doses, if they were given, 8.4 letters improvement patients achieved. If no loading doses, 7.2 letter. And if you look at the initial receiving 5 initial doses, treatment naive patients were around 52% and previously treated 31%. So that clearly shows that if the patients are having intensive 5 monthly injection, they can achieve further improvement in the vision. So again, important thing is what is the initial visual acuity when you are starting the treatment. So best corrected visual acuity is really important, and you can follow it up to the 12 months. So if you see here, less than equal to 24 ETDRS letters, you can get more improvement in the vision. But if you look at here, mostly numbers are here. The baseline vision was between 24 to 70 letters, and you can achieve 9.3 letters improvement in the vision. So what does that mean? If you are giving the 5 loading doses, it's a higher number of the patient in which you are going to get improvement in the vision in comparison to overall cohort, and which is shown here. There is another real world evidence that has come from the Moorfield study, and that again showed that you can get reasonable improvement in the vision regardless of what vision was at the baseline. If you look at the number of the injections at 1 year, 7, at the year 2, 2.9, at year 3, 2.6. So gradually, as we were talking earlier in protocol T as well, so initially you give the higher number of the injections, next year you have less number of injections required in these patients. And 58% of the patient in this cohort, they have baseline vision less than 70 letters. So which again is a significant thing, and they showed improvement in the vision. So Western another, this is a large database which is a US based, and it's a large number of the patients which were analyzed retrospectively. They had looked as well at 1 year. And what they have shown, amongst 28,000 eyes, 50% receive less than 6 injections in 1 year. What does that mean? That the patients are under treatment in the first year, and that really matters when you are managing your patient. So Fighting Retinal Blindness Registry, again it's a large database which also showed that less than equal to 68 letters of the vision at the baseline had significant greater visual gain at 12 months. And if you compare it, so here they have shown the comparison between ranibizumab and Afibercept. And you can see here at the baseline, and once after giving the injections, you can see that there is a significant improvement in the vision. Here you are seeing more injection in Afibercept group in comparison to ranibizumab, but that is statistically insignificant. They are almost same number when they look at. So a careful designed observational study, and it has it showed that it is unlikely to overestimate the therapeutic effectiveness of this agent. And eyes receiving Afibercept, they were more versi. They have less visual acuity in comparison to the ranibizumab group, and they were having thicker macula, but still they showed better outcome. And as I already mentioned, that rate of switching.
Hello, 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 hello.
So even here, if you look here, the baseline vision, if less than 68 letters, which is shown here, these were around 47% of the patients. So
Hello, 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 hello.
here in this case, 5 loading doses, and then patients were moved to 2 monthly injection or 8 weekly injection, so which is a significant thing. And even the vision is better, those slight difference, but again, Afibercept was better. So DRACO, that's again an important trial which has shown gain in visual acuity. It's a prospective 2-year trial about the diabetic macular edema that was performed in UK. And if you look at, they have basically defined a different baseline best corrected visual acuity. So less than 35, 35 to 49, 50 to 69, 70 to 78. So important thing is that if less than 70 letters, you can see that there is significant improvement up to 7.3 letters improvement. And another important thing, that the greater than 75% of patient, their diabetic retinopathy severity level remained same from the baseline. So there wasn't any worsening of diabetic retinopathy. Composed Polo et al., that is for the Spanish study, bit small study, but that also showed that significant improvement in the vision you can get from the baseline coming up to 14.9 letters at 12 months. And they again used 5 intensive loading doses and then moved to 8 weekly, and they showed great results. Similarly, central macular thickness, if you look at from 460 microns, it comes down to 229 microns. So a lot of studies on the real world evidence are going all over the world. So you can see either in the Europe and the American region or Asia, there are a lot of studies, and more than around 20,000 patients which were included, and they all have shown that if intensive treatment is given initially, patient will have a better outcome. So I think protocol T, I briefly touched it, it's already mentioned here, so we know that it shows improvement. But important thing is that intensive treatment, so here protocol I and protocol T is shown. Protocol I basically was about ranibizumab with the deferred or prompt laser, and they again showed that the later year patients were requiring fewer injections. So if you look here, first year around 8 to 9 injection, 2 to 3, 1 to 2, year 4 only 1. And similarly, if you compare ranibizumab Afibercept group, you can see that at 2 years the injection numbers is reduced. So if you look at the post hoc analysis of protocol I and protocol T, that again has shown up till week 24, there is a significant reduction in number of the patients who were having persistent macular edema, so that showed improvement. Similarly, in protocol T, you can see at week 24, so all agents are working. Definitely Afibercept was superior, but all the agents had reduced the burden of the disease, and the diabetic macular edema was reduced. So here it's shown basically comparison from year 1, baseline year 1, year 2, and by year 3 you can see that the rate of resolution of chronic persistent diabetic macular edema reached up to 60%, which again is a significant thing. And similarly in protocol T, they have shown that up till year 2 and there was a reduction of the fluid, and again Afibercept was better than the other agents. So that again, it's showing mean change in best corrected visual acuity at 12 weeks. So there is Eylea is definitely superior if you look here after 18 letters improvement. So coming to the summary, I think important thing is the results from all that clinical trials which I have already mentioned. They used 5 monthly loading doses, and they have described better outcome in the patients. And we all know that after the year 1, the patients will be requiring lesser number of the injections. So intensive treatment is definitely superior to your patchy treatment or just 3 loading doses in diabetic macular edema. And the patient keep on improving even the later stages. So year 1, some patients, even if year 1, they may not have significant improvement in similar way, but if you persist with the agents in year 2 or 2, they may be showing further improvement in the vision. So Afibercept achieves meaningful vision gains according to these trials, and that has been shown in clinical practice. And Afibercept can achieve clinically meaningful vision gain and maintain vision regardless of the baseline vision, which again is an important thing, because previously, as we know, we talk about it, the vision is poor already, they may not be improving, but it's not like that. In the clinical practice trials, they have shown even if the less vision, but the patients are timely managed, they will show the improvement in the vision. Thank you very much.
Thank you so much, sir. I would like to open the hall for any